to chair this occasion, we have with us the foremost development economist in Edo State that I know, and in Nigeria, because I've read some of her publications in international and national journals. I first met her in the Cyber Cafe on Airport Road, NUJ Center in those days. And I was wondering what a professor was doing there. I now realize that it's research. Research will take you everywhere. To chair this occasion today, therefore, is Professor Mrs. Christy. Professor Mrs. Christy Okoje. Ma, you're welcome. She is retired from active lecturing, but she's still very active in development matters. So you are welcome, ma. You are welcome, ma. And we have two discussants today. One of them is Professor Lawrence Omo Agoja. She is giving the keynote address. And Professor Omo Agoja, I met him long ago, but he has risen so tremendously in the academic environment. He is of the Delta State University College of Medicine. You're welcome, Prof. Okay, I understand he's now the provost, almost vice chancellor. So please, when you are vice chancellor, I hope you give me work. And we also have here with us Dr. Mrs. E.O. Obari-Siagbon. She is the Executive Secretary of the Primary Healthcare Development Agency of Edo State. Madam, you're welcome. Thank you for joining us. Thank you. Thank you. Now, we have a lot of our community members. Work is located in Igwe Iheya. At the time, we thought it was Ukowo, until they told us never. It is Igwe Iheya. And since then, we have had lovely relationship with the community. So we have a large contingent of the community here today. They are led by Pastor Stephen Igbineweka, the acting Ojonwe. Sir, you're welcome. We have Mr. Ojo Abonwande, the General Secretary. We have with us broadcaster of repute, Mr. Loki Edokpaye, Assistant Secretary. We have Mr. Fred Bowanigbe Okairele. We have Akim Obebo, a member of the community. We have Mr. Mark Asemota, is an elder of the community. I'm glad you came with the women. We have Mrs. Margaret Ogunyi. We have Mrs. Esther Ojo. We have Mrs. Osa, I want to say Ojo. We have Mrs. Helen Ogbebo. And from the University of Benin, we have Mrs. Ogono Gloria of the Public Relations Department. We have with us Mrs. Igodala, Barrister Igodala. She's senior counsel in the State Ministry of Justice. We will take further introductions, but let us just move on. Can we have the national anthem? Okay, we read the second stanza of the national anthem as our opening prayers. Can you please put it there? Can we rise? We will read it, or maybe you read after me. O God of creation, congregation, direct our noble cause, guide our leaders right, help our youths the truth to know, in love and honesty to grow, and living just and true. Great lofty heart attain to build a nation where peace and justice reign. Thank you very much. Well, before I take my seat, my name is Wilson Imogan. We have with us the program advisor and the spirit behind the Women's Health and Action Research Center, Professor Friday Okonofua. He is also the center lead for CERI, Center of Excellence for Reproductive Health Initiative in Innovations, yes. Okay, Reproductive Health Innovations. And today, we are going to address the issue of leaving no woman behind in access to reproductive health services. WAC as a body, since 1993, has worked tirelessly to put women's health in the front burner of national and local discourse, because that is our mission, to ensure that no woman is left, and we promote their well-being and social development. That is what WAC stands for. In doing this, we have had a lot of researches, discussions, advocacy that have helped to modulate and initiate policies in this country, some of which include our work on abolition of female genital mutilation, where the first law passed in this country was as a result of our advocacy. And not too long ago, we were aware that except the primary health care system is functional, our women in the rural areas will be left behind. So WAC led a coalition of NGOs to the Speaker and the Governor of Edo State, and we are proud to say, as a result of that, we have a very well established now Edo State Primary Health Care Development Agency. WAC has also worked in the rural areas. In fact, in Edo State, there is no local government in which WAC has not worked. Research, intervention, and service delivery is across the state. Right now, we still have ongoing projects in places like Okwekwe, in Ewato, in this local government, Ovia Northeast local government, and some of them in collaboration with government, others with support from partners across the world. Our goal is that no woman should be left behind. And happily, the Sustainable Development Goals, which is winding down, because in 2030 it will be reviewed. One of the key goals is that nobody should be left behind in healthcare. We want to welcome you on behalf of the Women's Health and Action Research Center, Board of Directors, the management, and our associates to this seminar. and want to employ you to sit back and take home some messages that will help to change the processes in this state and in the country. Thank you very much for coming. Mr. Chairman, can I say Mr. Chairman? Okay, Madam Chairman, please permit me to invite the program director of SERI to just give us a little address. Thank you.
Good morning, the chairman. My name is, good morning everybody. My name is Vivian, and I'm the program manager for the Center of Excellence in Reproductive Health Innovation, SERI, at the University of Benin. So SERI works and partners with WAC to promote health of women and children. The project started in 2014, and it ran for 5 years till 2019, and we got a new grant, which we are continuously running now. And we are there to train master's students and PhD students in nursing, health economics, reproductive health, and community health, public health. And this program is open for everyone, especially students from the region across Africa. Here I have my Malawian student who is currently doing a nursing program in the project, and also another student who is also a reproductive health student. So we partner with WAC to do research in the communities, because we need to make impact in the nearby communities where we are. And I'm happy that we are collaborating with WAC today for this Women Health Action Day, because I call today a WAC birthday. So we are here to work with them, and we are here to partner with them. And I welcome all of you here, the discussants and the keynote speaker. So thank you everyone for coming.
Thank you, madam. Moving across, a little bit of consultation.
Good morning, everybody. So first of all, I want to thank the organizers of the workshop, in particular Professor Okonofa, for inviting me to be chairman of this workshop. I don't know what exactly my duties are supposed to be, because in most places I've been to, the chairman is just like a figurehead. The MC takes over all the talking. But I'm happy to be here. So I'm actually here because of Professor Okonofa, because he only told me last week. I would have told him that you didn't give me enough notice. But I'm happy to be here. So for many years, I was doing a lot of work on women and health. But then I couldn't persist, because as an economist, each time it's time for promotion, they will say, oh, you're not doing economics, you are doing women's business, blah, blah, blah. But then I actually won World Health grants to do studies. I traveled to so many conferences on women and health and so on. So I am conversant. So I don't want to talk too much about the details, because we have a keynote speaker. So when the keynote speaker has given his own address, if there's any other thing that I want to add, I will add it. So I thank the community for being here, and also for bringing women, because the program is actually about women. Do I have my reservation about that? So I don't want to give my reservations at the beginning, because some of them are controversial. So at the end, when I'm giving my closing remarks, I will give you my observations. Because for many years, I've been working on gender. Since my PhD in 1981, 40-something plus years. I was one of the first people to be working on women's issues. Then we were very few. Now there are more women working, both, well, some men too are also working in that area, like WAC now. But there are a lot of things that are happening now that I did not expect to happen. When we were advocating for women's empowerment, I don't think we foresaw some of the things that some of our younger generation are now doing, which I'm going to observe at the end. But for now, I want to welcome everybody, both those who are already here and those who are still on their way to this workshop. Welcome, everybody.
Thank you very much, ma. I told you that she is one of the foremost economists in the field of development. We know that today, people will like to attend marriages, isn't it? People will like to attend burial parties. People will attend birthdays. But such an academic discussion to be held on a Saturday is unusual, I'm sure. We are expected to be celebrating party here. But we had to choose today because all over the world, 28th May is the International Day of Action for Women's Health. And we felt like if we did it yesterday, it would be out of time. If we put it on Monday, then we will be totally out of time. So we decided to put it for today, knowing that those who believe in the health of women and men will be here today. So I will not take too much of your time. I'm sure by 1 o'clock we should be out of here to attend other functions. So please bear with us. Let me... Yes, okay. Professor Okonofa.
Dr. Imogan did not introduce himself. He's the Executive Director of WAC. So I thought he was being humble. But also to emphasize the point you have just made about why we are here on Saturday rather than on a weekday. I think for academic meetings, where we discuss intellectual things, the people tend to come more on a weekday than on weekends. But on weekends, they prefer to go to marriages and so on and so forth. So bear with us, but I'm very happy that even though the audience is few, we have very high quality representation. I'm very pleased with the fact that our immediate community members are here. And we'll hear a lot about why women, why are we focusing on women, why does work focus on women. I'm very happy that Professor Koji has said that we'll explain more as to why that is so. But because of the fact that it's a Saturday, we have actually also made this on a feast day. So there's going to be a lot of lunch. We are going to have buffet lunch. So please don't run away because we've invited the best cooks in Edo State so that even though it's an academic meeting, towards the end, we are going to have lunch. Anybody that wants to dance, we have music, but I don't know that how it will work. So please, International Women's Day is it's served all over the world to celebrate the fact that women have peculiar health needs that men don't have. And I remember when work started because there was a conference held in 1994, which is called the International Conference on Population and Development, which focused on women being the center of discussion around population and development. Before then, everybody was talking about family planning, that the only way to control population and to make development happen is to reduce population growth. But after then, they discovered that women were dying from just having birth, and that even the so-called, when we use the so-called population reduction, control of population cannot happen if women are not taken care of specifically. So they added women empowerment to the doctrine of family planning, which we call a paradigm shift from just a narrow focus on population development growth, reduction of population, to the overall well-being of women, ensuring that that if women are empowered, they have better education, they have economic empowerment, they are the ones more likely to think of population and family planning, use of family planning methods. But if a woman is not educated, she does not have economic means, then she's likely not to think about fertility reduction, and so on and so forth. So they added the element of empowerment. And if you hear about women empowerment, it's not a joke. We're talking about social empowerment, education. We're talking about political empowerment. We're talking about empowerment in spheres of equality. When we say gender equality, we are serious. Because women and men are equal in many biological senses. And more we're emphasizing the fact that, in policy making, and that's why we're very happy to have the director of the National Edo State Primary Care Development Agency. When women are considered in relation to men in many aspects of life, that development will happen for the country. So WAC is at the forefront of those organizations that aim to promote women's development and social empowerment in all spheres of life. And that's why we are saying that today's our birthday. Somebody said today's our birthday. It's correct. Because that's what WAC stands for. And therefore, today we're not just doing a lecture, we're always celebrating that day and also celebrating women and celebrating WAC. So please don't leave. Stay with us and celebrate the good food that will come out from this place today. So thank you very much, ladies and gentlemen.
Thank you very much, Prof. I think we are moving on. And our first speaker is the keynote speaker, Professor Lawrence Omo Ahoja. He'll be speaking to us on strategies for the inclusive delivery of maternal and child health in Nigeria. We must save the women so that our children will do well. You come in this way, sir. Okay, come and stand. Incidentally, Professor Okonofa was his mentor, so he wants to describe his mentee and students.
I've known him for several years, and he's one of my, what I would call, people I'm very proud to have developed from the University of Benin Teaching Hospital. Professor Omoja has MBBS from the University of Benin. He's a fellow of the West African College of Surgeons. He's a surgeon, a gynecologist. He's a fellow of the Obstetric Gynecology, Nigerian National Postgraduate Medical College of Surgeons, Gynecology, as well as the International College of Surgeons. I am extremely proud of Professor Omoja. He started as a resident. In fact, when I came back from Ife those days and came to Benin, he was one of the first set of doctors I trained as a gynecologist here at the University of Benin. Subsequently, he went to Delta State University, and within a space of 4 or 5 years, he rose to the position of professor in the Department of Obstetrics and Gynecology at Delta State University. And is currently the provost, when we say provost, College of Medicine of the Delta State University. Professor Omoja is very, very well published. He has several publications in international journals, and he has books. I thought he was going to bring some copies of his books here today. So he's one of the gynecologists I'm extremely proud of because he followed my footsteps. He's one of those I can say that he's following my footsteps. So when I was looking at somebody that would deliver a lecture in the way I would thought about the lecture, I said, Professor Omoja in the whole country is the only one that can do so. So it's indeed my pleasure to have you here today. Thank you very much for coming.
Thank you very much. I describe him as always my boss, my mentor, a great friend, and the one that always stands in loco parentis for me any day, anywhere. So I'd like to thank Professor Okonofa for that kind citation and accepting readily to get up to do that job. So the chairman of today's occasion, Professor Koje, I'm just wondering now that I'm standing here that you're probably Caroline's mom, and Caroline was my classmate in medical school, yeah, and we're always in touch. So thank you very much for coming. Other distinguished members of this audience, the Director of Primary Healthcare Development Agency, the Executive Director of WAC, Uh, I've known him for several years. I remember when I was doing house job in Central Hospital, Benin. That was the first time I went to his clinic. He was running the skin clinic there. And he was such a pleasant senior doctor, and he has always remained so. So I'd like to thank you for kindly accepting to invite me to give this talk. When I got this notice, Strategies for Inclusive Maternal and Child Health Care in Nigeria, the first question I asked myself is that, what new are we going to talk about? Strategies for inclusive maternal and child health in Nigeria. Because I can still recall vividly when I was very small, maybe I was in secondary school, I kept hearing the slogan and popularly mentioned and advertised everywhere, health for all by the year 2000. And then we used to ask, and they used to tell us that by the year 2000, nobody would die in Nigeria anymore. Health care will be at our beck and call. We will just look at the corner, we'll find a health facility. And that no woman, no child will die. Eventually, we started hearing about that slogan, Child Survival Strategy, and everybody kept talking about it. And we were told, too, that in not too long, no child will die prematurely or suffer from common diseases to which almost 50 years after they still die from. And I remember in the last space of about 20, 22 years, I've been actively involved with the issues of maternal health and child survival. And I was asking myself, what have we not done? But suffice for it to say that I would not just go to the strategies as it may be, because I believe that maybe if we talk about the strategies alone, we will forget them so fast and we may not implement them. But if we actually look at the story of what drives us to not think about inclusive maternal and child care, then we probably understand the import of it. And then, of course, it will sink home the message, and we're likely to drive it much, much better. So I would deliver my address this morning looking at the issues at hand under this outline. I'll give just a small background. Then I'll look at maternal and child health in Nigeria, the challenges facing them, and the enormity of it. Then we'll look at global and national responses and efforts. Look at the historical song we have had to make over the years. Then we'll now look at what are those challenges that have confronted the responses and efforts we have made to try to address them, and why have we not won. And then we'll now look, I'll not just probably highlight the concept of inclusive and maternal child care, and I would like to add respectful care too. And then, of course, I will propose some strategies that I think may work, then we can discuss after other presentations. So it's just suffice to say that maternal and child morbidity and mortality continues to be a major public health challenge all over the world, but it's worse in middle and low-income countries. And we believe that the low-income countries are worse hit. And despite all global efforts to reduce maternal and child mortality, the availability and utilization of maternal and child health care remains low in many low and middle-income countries. Now, even if we have the health facilities situated around, they are grossly underutilized. And why is this so? Now, let's look at the scope of the problem and the enormity of the challenges maternal and child health continues to experience in Nigeria, because that's our focus this morning. Now, it's always said that if you want to evaluate the developmental indicators of any nation, the maternal and child indices, as it concerns morbidity and mortality, it clearly shows a difference between what a developed nation is and what the underdeveloped or developing nations will be. Now, let's take the maternal indices and look at it quickly. Let's look at women who are pregnant and then the lifetime risk of them dying as a result of the pregnancy processes. This is how it stands, and these are the figures. You can find out that in Africa and developing nations, the indices is very poor. In Africa, we can have it as 1 in 16 chance of dying and 1 in 18 chance of dying. For every woman that dies, about 42 others would live with long-term morbidities, complications that they will live with all their lives. Whereas if you look at the developing nations, their parameters are quite interesting. But the sad story is that maternal mortality, child mortality, despite the fact that it confronts us so badly, it is one of the very neglected tragedies of our times. Nobody bothered so much about it. If you look at in 2020, when all over the world we evaluated and looked at how many women would die per 100,000 live births, it was 152. The year before it was 151. So it meant that we're not really winning too much. We are not, whatever we are doing is not really making much impact. About 4 or 5 years ago, down to about 10 years ago, if you look at maternal death in Nigeria, it was about 546. But by last year, it has risen again to 814 per 1,000 live births. It then means that we're not really winning. That's why all we're doing. And if you look at it, we have one of the worst set of data in Nigeria, whether maternal or child data. And every year, about 303 women die, and approximately 830 women die every day from pregnancy and pregnancy-related issues. So it's just like you having a Boeing 747-8 crashing every day. That's what happens. And yet, we are not really bothered much. If we have 2 pilots, probably Nigerian soldiers, just doing some reconnaissance movement around Kaduna Axis, and they crash, there are 3 crew members. It becomes a national headline. In fact, we can declare 1 week of national mourning. But that we have every day of women dying. And like we said, the death is just a tip of the iceberg. In a year, over 300 million, currently over 300 million women are living with long-term complications of pregnancy and pregnancy-related process. And every year, 20 million more occur. And 99% of this happen in developing countries. And if you cone it down to the sub-Saharan Africa, not just the whole of Africa, our region here, sub-Saharan Africa, 84% of this death is due to death in our region. And if you take developing world, in 90 minutes, 1 woman will die. But in our settings, in every 10 minutes, 1 woman dies. It therefore means that we have 100 times chance of women dying compared to the developed world. It's interesting to know that we contribute 10% of these maternal deaths and complications, whereas Nigeria contributes just 1% to the world population. And it's quick to mention that maternal and child consequences are tied together. Anything that affects the mother in pregnancy, labor, delivery, or post-delivery ultimately will either affect the fetus, the newborn, or the child. And so they are closely intertwined. What affects the mother, either medical complication or other intermediating factors, as we'll see, will equally affect the baby. Now, let's look at all the other parameters. Women receiving antenatal care, no more than 60% of them have access to antenatal care. And then, let's look at delivery. About 65% of women will deliver at home. They do not have any form of assistance. Now, 17% have no assistance. Then 26% of women are assisted by women who have no training at all. Our HIV prevalence rate has risen. Most data now show 8.2. Some years back, we were talking about 5%. So it really shows we are not winning. We have very high cesarean section rates, but the access, where they can get access to that is very poor. And I'm sure you will know what we call VVF. Women that leak urine after they've delivered, as a lot of complications from that. we have one of the highest set of figures in the world. Our demographic health survey shows about 800,000 women living with those problems. Now, like in many countries in the world and in Sub-Saharan Africa, these are the reasons why women would die, medical complications. But the question is, why do they not die in developed nations from when they suffer these complications? And why do they die more in developing nations? Why more in Sub-Saharan Africa? Why more in Nigeria? Now, maybe this story would make it very clear to us. Some very long years ago, one of our very foremost gynecologists, Harrison, was working in Zaria, published some work in the British Journal of Obs and Gynae, and he titled it Childbearing, Health, Social Priorities, a survey of 22,774 consecutive hospital beds in northern Nigeria. He noted that these women didn't just die because they had these problems. When he evaluated it, some had the problems and they came out clean. And those that died, he noted that they had social, they had cultural, they had educational factors that were intermediating, that led to their deaths. And he now added that a subset of them, when he analyzed them, 6% of the mothers were under 15 years. And those 6% accounted for the overall 30% of the maternal deaths. So it means that if the social, cultural, and educational factors, an issue of early marriage is probably addressed appropriately, even if you have this complication, even in our environment, you're not likely to die from it. And then, of course, other factors which we already know that may operate are well classified into the types of delays we have, type 1, type 2, and type 3. It just simply means that it's not because of the medical problem. You have a medical problem, you want to go to hospital. The type 1 is that there are so many challenges that will not make you leave your home to go to hospital. It may be financial, it may be cultural, it may be social, it may be all other issues. Maybe the person to give the permission for you to go to hospital, maybe the head of the family, either man or woman is not at home, so they are waiting for that person to come to give permission. So all those ones come under type 1. Type 2 is that you have problem leaving your home and going to the hospital, either because there's no transportation, you do not have money to afford transport, or there are a lot of issues. The hospital is too far away and all those ones, so you can't move. And then the other one is you get to the hospital, you are not able to get care. Now, let's look at child morbidity and mortality. When we say child morbidity and mortality, we're actually looking at children under 5. That's why you find that most governments are talking of under 5, free under 5, like in the state where I come from, Delta State. And usually it encompasses those that will die early and those that will die in the first day of life. Now, if you take that all over the world, about 8.1 million children die every year from issues either from surrounding pregnancy or other social issues or economic issues after they've been born. Now, the highest figures, again, from Sub-Saharan Africa, we have about 74, with a range of 68 to 86 deaths per 1,000 live births. Now, in Sub-Saharan Africa, where we belong, a child is likely to have 15 times more chance of likely dying than in well-developed countries. So if you place somebody from the UK and America, and you place a person from Nigeria, so Nigeria has a 15 times chance of dying compared to the person from the other developed countries. Now, let's look at, can we scroll up a bit? So the next thing, well, I'm just trying to give you a comparison for you to understand the enormity of the problem we have here. The next slide, please. Go to the next slide. Look at our figures. In all the quarter, either under 5, infant mortality or neonatal mortality, compared to West Africa or Central Africa and the world, our figures are worse off. Our figures are very bad compared to that. Now, it's true that in the last few years, we've made rapid progress in the reduction of child mortality and morbidity. But has that translated to a reduction in our setting? The answer is no. The answer is that we still have a huge burden of it in our setting for obvious reasons. And if we have 15,000 deaths every day, and about 84% is from our setting, then it's huge burden. If you look at it, again, let me just give a graphic description. A jumbo jet carries 620 persons. And if you divide that by the 15,000 children that are dying every day, it means that 24 of such jets will crash every day, carrying 620 children alone. The pilot is a child. The assistant pilot and the crew members, they are children, they'll die every day. 24 of such. And over 50% is from our setting. And yet, nobody really bothers. It doesn't make a news. We are not bothered. Either community, either government, either religious setting, either government. Everybody just moves about as if nothing has happened. And 80% of that will contribute to that. And if you look at it, there are 6 key countries in the world that account for almost all those deaths, half of those deaths. We have China, we have India, we have Pakistan, we have Nigeria, we have Ethiopia, and we have Democratic Republic of Congo. Those are the 6 countries, and Nigeria probably seems to be, has one of the worst set of figures in this contribution. So child mortality, clearly, and maternal mortality is a tragedy we see every day that really makes news. Now, if you look at child mortality again, the reason why they die is not different from why they die in other places of the, this is not different from the same problem children have in other parts of the world, but they don't die. And so why don't they die? So those are the issues. So the main thing that leads to death is not just because they have these medical complications, it's a lot of intermediating factors, social, cultural, religious, economic, and all other factors contributing to that. Now, let's quickly look at the responses we have had over time. Now, most maternal and childhood deaths are not only preventable, but they are completely avoidable. If you look at Nigeria, we have currently ongoing very few programs that really address maternal and child mortality. Now, it does appear that from time, the world has known that there's a need to integrate maternal and child care. Because if you look at the seminal publication by the Alan Rosenfield and their colleagues, they were working in Columbia University in the mid-80s. They raised this critical question in their Lancet publication: where is the M in MCH? MCH means maternal and child care health. But they were raising the question, where is the M in the MCH? It means that for long, even before now, the concept of caring for mother and child has been well integrated, but we didn't bother much, because what they were hearing there and we heard was child survival strategy, GoBF, and all those ones. We were hearing about that. So they asked that critical question. At that time, the only few aspects we talked about for women were just family planning. They were just like reproductive machine, like the oven that bakes the bread, or the pan you put the flour to bake the bread. When you finish, whether it is still available for the next one, it doesn't matter, you throw it away. So it therefore means that there had been intention that this should be integrated. So from that question they raised in the 1985, then the world started putting together clear strategies as response to these maternal deaths. The first one we readily have come to our mind is the Safe Motherhood Initiative, that packaged all strategies that will ensure no woman suffer in pregnancy, labor, or delivery, and that the baby should not die too. So that was the first strategy. Then subsequently in 1994, we had the mother and baby package, because it was not very clear that we need to integrate them very clearly, all the interventions that needed to go together with it. And then it was not enough. Like Professor Okonofa mentioned, it was not clear that until we started adding rights issues and looking at issues of the sexual and reproductive health as an essential element for survival of both man and woman, particularly the woman in terms of when it comes to safe motherhood and child survival, that we will probably not win. And so the ICPD, International Conference on Population and Development in 1994, came out, and part of their program of action was rights issue and clear definition of sexual and reproductive health to capture maternal health and the survival of the children. And subsequently, there was ICPD Conference +5. And then, of course, for those of us who followed closely, there was the World Conference on Women in Beijing, and then and the subsequent one that followed in the New York or so, +5. Then we've all heard about Robac malaria, trying to survive mama and baby. Then eventually, when the 2000 came and the year the Health for All didn't work, of course, we packaged again the UN, under the leadership of the UN, the Millennium Development Goals. And two of the 8 goals were clearly focused at maternal health and child survival. But then if you look at all the 8 goals of the MDGs, if you implement them, then you mean that health for all, including mother and baby, is assured. But again, we were hoping that by 2015, we would have won. By 2015, we didn't win again. And so we had to rejig and came up with the Sustainable Development Goals. We have 17 goals, with goal 3 clearly taking care of a number of health issues that will help us. Now, what were our national responses? Clearly, Nigeria is known for embracing all international initiatives. We probably will be the first in the world to embrace them. We did embrace all these initiatives, signed on to them, promised to domesticate them, and translate the policy of adopting them into action. But whether we did is a different ballgame. But it just suffices to mention that the Millennium Development Goals, we used to make a jest of it that even though there were 8 goals, the federal government of this country probably said had about 9 to 11 technical committees or task force managing only 8 goals. But how we actualize the policies is a different ballgame. Now, let's rewind back that when Olikoye Ransom Kuti was the Minister of Health, he actually put in place that policy where if management of hospital do not show him their indices and data for maternal mortality every month, they do not get their subvention. There were all strategies to push in health facilities and health operators to ensure that the issue of maternal health is given a priority attention. And then, of course, some states went into enacting laws on maternal mortality and setting up monitoring committee. I remember then in the early days of these issues coming to the fore, Edo State was one state that the House of Assembly passed a law on maternal mortality and set up a committee for monitoring that. Some states responded by putting in place free maternal health care, and some added under 5. States that readily came to mind like Rivers, Kano, and Delta. I'm not sure whether we've evaluated our data to see whether we won, but if you look at an inductor report, it doesn't show that we probably won. The figures probably got better. NGOs were working on maternal mortality in Edo State, and our sub-region work is one of such. There was the Nigeria Partnership for Safe Motherhood. In 1998, we adopted the regional reproductive health strategies that had clear goals and items and targets for maternal health and child health. Then I remember some years ago, we talked about the midwife services scheme as a way of taking care to the mother and babies in the villages or the health centers. We were part of the state trainers and managers of that, National Primary Healthcare Development Agencies and SOGON, Society of Gynecology and Obstetrics of Nigeria. But that program is already dead. The problem is when the funders finish and they hand over to the government, it goes into extinction. Then, of course, child survival strategies. We talked about breastfeeding, immunization, oral rehydration, growth monitoring. We talk of GoBF. We talk of baby-friendly hospital initiative, integrated maternal and child care, where responses we put in place. Then we use, Nigerian government use these responses to develop policies. If you go to the Federal Ministry of Health, you see a lot of policy documents. But I'm not sure most, even people who are hospital managers, know about them. We have the National Health Policy of 1988. I'm not sure most healthcare managers have even read it to understand the dynamics of it. We have the Maternal and Child Health Policy. We have the National Immunization Policy and Standards of Practice. I'm not sure most people have read it. Even the nurses that run immunization centers have not read it. We have the National Acute Respiratory Infection Program, National Policy and Plan of Action. We have the Breastfeeding Policy. We have the Essential Drug Policy. We have the National Nutrition Policy, compiled in 1995 and 1998. We have the National Reproductive Health Policy. I'm not sure anybody has read that document. We have national policy on population and sustainable development. We have the water supply and sanitation policy, which was adopted in 2000, and it's in all the goals, all the initiatives, MDGs, SDGs, because it's important. One of the leading reasons why children die is from diarrhea diseases and waterborne diseases. And so we must have a strong policy, but then how does it translate? Even in this country today, I'm not sure any state, even not even Abuja, has any organized public water supply system that is well treated, that is safe, or otherwise. Either we drink from borehole, or we drink from wells, or we collect from the rain. The government adopted the fortified food with vitamin A. How many children in this country get such food, or even know about the policy? There's a national program of action for survival, protection, and development of the Nigerian child. There's a national policy on women, which strives to enhance the status of women and the mother and child component of the National Primary Healthcare Development Agency. Our director is here. I don't know whether they are implementing it. The Federal Ministry of Health strongly supported the rollback malaria and all the guidelines. In fact, it was some years ago when I was looking for a document. I sent a paper to a journal, and the journal said they would like me to state the Nigerian policy on malaria control, that they are aware that the government of this country has a policy like that. So I called my friend who did the work on malaria control for his dissertation, and he said he wasn't aware. So I took a trip to the Federal Ministry of Health, and my friend then, who was an aide to the minister, took me to their storehouse, and they opened the place. We started searching. There were so many policy documents that even they themselves are not even sure whether they had. And so it's as bad as that. So we don't translate policy to action. And so all these policies are things we have continued to be with. And so you can see that now the problem we have is not that we have not responded. It's not that we have not made policies. It's not that we have not made effort to release money to have committees work. But the point is, have we translated the policies and programs to action? I'm scared. The answer is no. And so it therefore means that we must be asking ourselves why we have failed. Why, despite all these efforts, global and the responses, and despite the fact that we know that our burden is as huge as we have presented this morning, why have we not been able to address them? And so we must ask ourselves, what are those challenges that have continued to confront all the global and particularly our regional initiatives and our country initiative, where we have not been able to win? And so we will look at it. I'll just mention a few. I'm sure the discussants will mention others. Now, some countries, even they are resource poor like us initially, they've been able to harness it and make theirs work. And so they've had appreciable reduction in these indices we're talking about. But Nigeria's story has not changed. Our indices are probably getting worse. And interestingly, most of these our reports does not actually capture the community survey. We just use hospital data and some few surveys we do. So it therefore means that if we actually do a complete community survey, it may be worse than what we have. Now, the first thing that comes to the fore that makes all this not work is lack of strong political will. That's the truth. We recognize that the primary healthcare development agencies should be strong. At the time, the federal government responded. I'm sure it was under Olusegun Obasanjo, I can't remember. They built primary healthcare in all the local government areas in this country. They, after building those beautiful structures, fenced around and everything, I'm not sure it was ever launched. Facilities were probably not brought in. They were brought in, they were vandalized. Doctors, nurses, and health personnel were not provided. Most of those facilities today have been taken over by grasses, or people have even acquired those centers. So there's lack of political will. And then again, coupled with that, there's poor planning and funding by government. You know, they never thought about it, but somebody just awarded the contract, let's build those local governments. We didn't talk of how are we going to manage it? How are we going to fund it in the long term? Then, limited intersectoral approaches. I do not think that the federal government should start dealing with secondary and primary health care without having a nexus of connection between the states and the local government. So that we must be sure in our mind the long-term sustainability of such interventions. Because if you don't do that, you do it, the state will just be on the side watching you. The local government will be watching you. And that was one of the problems the midwife services scheme ran into. Because what was clear was that our local government, our villages and these things, where people really die, they have health centers, but there was nobody there to work. And so the concept of having midwives who can give skilled birth attendance at birth and supervise antenatal care, manage basic problems of baby. Then we were teaching them on the initiative called Helping Babies Breathe, so that they can resuscitate, they can manage until they refer, if they need to refer. And so they were trained, they were supposed to be housed in the local government and provide basic amenities and well paid. But they got to a time, they were owed such long months, and the poor women and some young men who were part of it had to leave the villages, and the program died. So those are the issues. Then again, we talk of lack of decentralized management capacity. If you look at Edo State, for instance, thank God I was talking with the director of Primary Health Development Agency. They seem to be spreading doctors now to health centers and primary health care and sending nurses there, which is a good initiative. What you have is that the real standard of care is considered in the center, UBTH, Central Hospital, but the other health facilities, you get there most times, they say there's nobody. And that is the one that is near the people. And then, of course, non-sustainability of donor-funded programs. I mentioned this midwife services scheme. As soon as the Primary Healthcare Development Agency, national, handed over to state, the state governors refused to take possession of those programs. Even then, we used to mention that one of the governors that opposed it was the governor from my state. He was a sitting doctor. And we were very upset with him in the national meeting we had when we wanted to hand over to state. Sogon did the same thing. When Sogon funding finished, Sogon handed over to state. The state went to sleep, and the program packed up. And so we continue to have that. Now, we did this program on trying to prevent women from dying from hemorrhage. It was called the Woman Triad. Over 193 countries in the world, Nigeria was part of it. I was principal coordinator for Delta State. It was coordinated by London School of Hygiene, Tropical Medicine and Hygiene in England. We finished that program. Even the outcome of it, the state and federal Ministry of Health has refused to even buy into it and give vent to it. Simple drug that can be made available, a woman is bleeding in labor or after delivery, you give to her. We've not domesticated it. We equally did the one we call When Getting There Is Not Enough, funded by WHO. We finished the work. After the period of intervention, we handed over to state. It didn't work. Well, we just rounded up another one. We call it MPD, Maternal Perinatal Death Survey for Quality Equity Delivery of Maternal and Child Care. We finished that project. We've handed over to federal ministry, handed over to hospitals, but it's gone to death. They're not willing to take up and use the beautiful strategies we've developed to make things work. So once donors come in, they do things, there's no plan for sustainability. And then the other thing that we find is that there's high level of disrespect. There's high level of disrespectful care in most of our healthcare facilities. I'll give you instance. The healthcare facilities, most times, the operators of it do not take the sentiment, sensibility, and the feelings culturally, religiously, or otherwise of the clients that come there into cognizance. They do not even do enough counseling and get informed consent. Most times, a woman comes to healthcare facilities, she wants to be examined, there's so many other people around, the healthcare, either a nurse or doctor say, madam, just climb here. And because the woman cannot say no, she finds it very unacceptable. I mean, but she cannot talk much. Even if she talks much, they say, my friend, lie down there, are you the first person? What do you think we want to? You think you are interested in seeing your private part or what? And that thing hits the woman very hard. And then the woman gets back home. We never come back to the hospital when she has problems. And somebody else is going there. If she spreads the message that, I'm sorry, those people, they just do what they like. They don't even talk to you. They don't even tell you why they're taking you to theater. They don't even tell you why they want to stick their hands into your vagina. They just say, madam, I beg, I don't want to go there. So we need more respectful care. And even if people have an objection, you must explain to them. Let me give you an instance. I had an experience, and that taught me some lesson. Now, a patient was referred to me with infertility some years ago, she and her husband. And I was managing them. I had put them on a plan of investigation and treatment. Then the woman came back and told me that, well, somebody, her neighbor told her that one of the things I asked them to do was not necessary, that it doesn't really help and all these things. Say so, whether she should really do it and all this. But I should have actually explained to her the reason why she should do it. And I got a bit upset and told her, okay, if you want to choose those people, choose them. If you want to choose me, choose me. So don't waste my time. And because the husband believed in me, because of the person that they continued with me, the woman got pregnant. You know, it was when the woman came 6 months, when the baby was 6 months, she now said she wanted to tell me something. She's a lecturer. That she hated me all this while, even though she got pregnant and managed that. Each time the husband said, let's, even not for the husband, she would not have come back to me. That's why each time she came, she hated me. She said, you know why? He said when she came to me, she didn't believe that that was superior. She just wanted me to equip her with the tool to go and discourage the other woman. Let me reinforce her confidence in what I have asked her to do. That's why she brought it up. That, but I just killed her spirit. That I just destroyed her spirit completely. That she didn't say she wanted to take that, but she came to me as somebody that has been sent away, and people were confusing her. That she was not confused. She just wanted me to reassure her, and that and even for her husband, to hell with me. I don't know if you understand what I'm saying. It took her almost 1 year plus before she told me that. If the husband didn't believe in me and they kept coming, she would discourage people from coming to me. So we must ensure that that is done. Otherwise, whatever interventions we bring may not be widely accepted by people. You know? But again, the other thing that makes health workers irritable is that either they are few in number, or they're not well paid, or they're old months. And so at times you come and you irritate them. And so we believe that for you to have a respectful care in the hospital or health facilities, you must pay them well, you must give them good working conditions, and there must be enough staff on the ground. And then, of course, socioeconomic factors, people are poor. So even if you say there's a beautiful hospital there, they will say, well, it's good, but there's no money in the pocket. Lack of adequate and relevant knowledge. People don't even know what are signs that will cause problem, what will kill a baby. When a child is having diarrhea and vomiting, they probably do not take it seriously. They don't know that if you do not act very fast, that baby is on the way out. As simple as you may think it is, that diarrhea and vomiting, the baby is on his way out. Even worse than the other illnesses you're talking about. So they might just trivialize it. By the time they bring the baby to the hospital, the baby is moribund. They may not even know where to go to, where to seek help, and where kind of help they can get. They may just have an idea that the help, if you go there, maybe they're not even supposed to pay, but they will think that. So we really need to equip people with knowledge. And then look at it again. Our women are disempowered. Then our women have low level of education. Where women are not empowered and they have low level of education, it has a lot of implications for their health and the health of the children. And in fact, the wellness of the community or society. If the women are well taken care of, the society is safe. So they say train one woman, then you are helping the whole nation, isn't it? Or community. If you train a man, you actually train only one person. Now, there are cultural issues that impact on health. We all know that. Then, the other thing we found out is that poor community involvement in most of our intervention programs, or lack of community mobilization. Now, WAC is here, and WAC is leading by example. Every simple thing WAC wants to do, the community is represented. Even from the outset, from the time the negotiation for this land took place, I'm quite familiar with that the community was told what WAC stands for. And that changed a lot of perspectives and how the community handled the negotiation for this land. So community mobilization is very essential. Otherwise, you may come with your intervention. They will say it's one house there. They are doing some things, maybe experiment or research. It doesn't concern them. And so the people may not go. So there's a strong need for community mobilization involvement, and I will tell you how that will happen. And then there are a lot of religious interference with healthcare. A lot of faith homes come up where they do all kinds of things. There are a lot of religious groups that say, don't go for treatment, don't take drugs, don't take blood, don't take this. And so a woman delivers, she's bleeding away. A child needs blood, they say don't give blood, and the children will die. So there are a lot of religious interference. And then our healthcare facilities are limited, very limited. Very, very. You may actually travel, some communities may actually have to fly a speedboat for like 2-3 hours before they can get to where the first hospital is. Some communities, if you are in all those villages, or all those ones, before you carry the woman from inside the interior to the roadside with bicycle on your back, the woman has died, or the child has died. So we need to take the healthcare facility close to our people. And that's where the Primary Healthcare Development Agency needs to be looked at. Some years ago, Olikoye and Sonkuti strengthened primary healthcare, but subsequent government allowed it to go. Lack of means of transportation. And then the most worrisome one is cash and carry policy. You know, emergency is likely to occur in a period where you have no cash on you. Either very late night, or when the salary is already spent, and you are waiting for next week to be paid. Because there's nobody in this country who earns their new salary that can have money in the pocket to provide healthcare. Nobody. Even if you are a professor or permanent secretary, if you depend on your salary, you cannot. So that's a major challenge. Now, so that's the problem we have. So we've had this problem, we know it. We have tried to respond. We are going to have responses, but it's not working. And we try to look at the challenges, why the responses are not working. Then what do we need to do? So that's why we're talking of inclusive maternal and child health care in Nigeria. Now, let's look at that concept of quality maternal care, which of course derives from inclusive and then respectful. You say quality maternal care and newborn care requires more than just access to interventions, drugs, and commodities. It's more than that, because we already have all of them available to us. We know all kinds of interventions, but they've not worked. You see, a fundamental component of quality care is respectful and inclusive. Care that is clinically safe, but importantly, feels emotionally and psychologically safe to the woman and her family, and they being active participants in the care. That means from day one, or from the time they present in that emergency, do not just start taking actions or moving them or giving them orders. Let the woman know, let the husband know, let the close relation know that this is what is on ground, these are the things we need to do and why we are doing them. And so they are participating with us. They understand what we are doing. We are not just giving orders, we are not just writing papers. Because you may just write papers and write papers, the man will just collect the paper and go home. After the man has exhausted the 20,000 naira with which he came, he'll just take the paper and go home and say, let the hospital keep the baby and the child, you know. So we need to understand this. So it must be respectful for it to be inclusive. Now, you say this means that the care must include respect, community knowledge and values, be tailored to the woman's and children's needs, and then importantly must be provided by health workers who can combine clinical knowledge and skills with interpersonal and cultural compliance. Say respectful maternal and child care encompass all these elements and much more, and needs to be a fundamental element of our maternity and child care. So if you build all this into the interventions you do, then you will carry everybody along, and then it will succeed. Now, how do we make women feel, or the community feel, to be part of it? Let's always counsel them, and let's get their informed consent. Informed consent means that we talk to you, you understand what we are going to do, and you agree with us that we should do it. And then you will go to any length to provide anything. We have counseled Jehovah's Witnesses, and they understood why we are asking them, and then they give up that faith belief that, oh, blood, give it to my wife, give it to my baby. We've had that done because they understood what we are saying. So it's important we know that. Now, the last part will be talking about strategies for maternal and child health in Nigeria. First is to say that all these responses we make, if they must work, then we must go back to the old concept we started some years ago, which is no longer very, very prominent amongst us. We must do continuous needs assessment. We have started intervention now. We want to expand the scope or want to introduce new items. We must do a needs assessment survey. It's a small survey. We talk to people in the community. We talk to people who live there. We may talk to health workers. We write a report. we analyze all the issues that are likely to be problems, and then we disseminate the report to you, just the way you are here. We will come and tell you that this issue that we're addressing now, that makes woman die or makes a child die, this is what we found out in the community. These are the challenges. And then whatever cultural, religious, and social issues that will stand as impediments to the community we are trying to serve, to take it, we'll highlight them. Then we have a discourse. We agree that there's a need to go in this direction, which we are recommending, based on which we are developing interventions. And the interventions we are going to develop now must be sensitive to the cultural, religious beliefs, sentiment, and sensibility of the people. Once we do that, they will accept it. And the intervention will live longer than us. We have had institutions where we intervene with TBAs, traditional bed attendants, who strongly believe that hospital has no place in delivery of women, even bone setup and all these things. But by the time they understood what we were saying, they not only improved on the quality of the service they were rendering and the cleanliness of their thing, they were the ones that would see a woman who is pregnant and say, sorry, this is your problem. They've taught us this problem. They say, if you have this, hospital. And those women were actually accompanying those pregnant women. Once they see a woman who delivers, she has complications, they say, look, my friend, don't come to my place. It's hospital. Some of them were accompanying them because they already understood, because they were part of the processes. We not just jump on them. We did this, we tried to understand why they were doing what they were doing, and then we had a report, we discussed it. And so that is very important. If any program or interventions will stay long in the community. And then we must put in place deliberate strategies to ensure that information, education, and communication on health-related issues, maternal and child health, and interventions that are available, and the scope of services they can get at every point is always available to the community. It's a continuous process. When the women come, we talk to them. When we go to the community, we talk to them. And that should be available. And then, it's clear that community mobilization must be key. Community mobilization is in so many, it takes a lot of perspective. See, beyond the fact that we are trying to ensure that those impediments are removed, then the community themselves can be mobilized to aid themselves. For instance, they can work out a transportation system where even those that have cars and vehicles can make them available in times of dire emergencies. They can actually do a small form of contribution in the community. Maybe 100 naira every day. They raise it, or every week. They have a pool of money. If anybody is ill or sick, a child is convulsing, they don't need to wait for the father. They know that this person keeps the money. Please, let's, from that pool of money, get a vehicle and take the child to the hospital and start some form of intervention before the child comes, the mother or the father comes. And then more importantly, we must educate the girl child. We must empower them. For those who are not going to school and eventually will go, they must learn some form of trade or business that will make them independent, not depending on the husband or anybody to support them when they need health care. Then our government, there must be strong political will to improve the lives of women by placing women's health and reproductive rights far ahead of the agenda rather than at the end of everything. That should be key. If that is key, then we will win. Then strengthening our primary healthcare development sector, all the primary healthcare development sector, small hospitals in the community should be strengthened. But beyond that, because we know they cannot do everything, there must be a good referral network from primary to secondary to tertiary, and there must be a good transportation system. Maybe ambulance services should be there. And like we said, we must ensure respectful levels of healthcare delivery in all the facilities. Better remuneration for our doctors and healthcare workers will help. We may be able to abolish cash and carry policy, which will be very helpful, and then we remove financial barriers to accessing health. One way we can achieve this is by ensuring that our health insurance policy, including the community one I talk about, is well established and robust. Then we must translate our policies to action. It's not enough to make policy pronouncement, but we must ensure that we translate them to action. Then we must ensure that all the low-tech, evidence-based, cost-effective measures that we adopted are given vent to. Vaccination, antibiotics, micronutrient supplementation, insecticide-treated nets. There are some homes, you get there, you see like 5 or 7, 10 insecticide-treated nets. They don't use them. That alone can prevent malaria if you use them efficiently and effectively. Then improve family planning and family care, breastfeeding practices, oral rehydration therapy. If a child starts stooling and vomiting, you know how to give oral rehydration therapy. You can actually manage her or him. But even if you don't keep her or him at home, before you get to the hospital, you will ensure that that baby does not go into a derangement that may likely be a problem to recover when you get to hospital. And then, of course, we may develop innovations in our healthcare system that will make the poor ones selectively favored to the rich ones. If you go to developed countries, the rich ones pay tax and some monies to give care to the poor ones, where when the rich ones are ill, they pay for it. And then, of course, simple tools. If we ensure that every mother that is nursing a baby, or everybody that knows that I need to nurse a baby or feed this baby, or take care of this baby, I need to just wash my hand first. Because simple transmission contact of simple fecal material, or you just gone to the toilet, you've not washed your hand, you may just transmit one organism to the food you are preparing for the baby, and that may be the end. So if we adopt such policies, that will help. And then the essential newborn care, which we already know, if we implement all of them the way they are stated, it will work. And then, of course, the last one I'd like to mention is improve sanitation and access to clean drinking water. Because one of the reasons why our babies die a lot is diarrhea diseases. And one of the ways they get it is lack of access to clean water, poor environmental sanitation. You may see our public toilet system or even the pit toilet system when it rains, all the other issues, and the children, our children play on the ground and all those ones. And then finally, I'd like to mention that half of the world's maternal and newborn and child deaths occur in sub-Saharan Africa, mainly due to poor healthcare access. These deaths are needless. Most can be prevented by strengthening health system on the front line, from the primary healthcare to the tertiary care. In recent decades, gains have been made in reducing deaths globally, but critical knowledge challenges still exist. With a strong political will, coupled with appropriate planning and funding, a respectful and inclusive approach towards maternal and child care should be the goal. Thank you very much for listening.
I think we can still give him another round of applause. The discussion was just a discussion with us, and addressed everything: government, practitioners, community, and individuals. And so it's everybody's responsibility to save the woman. Our chairperson will summarize later. The link between community, government, healthcare, and practitioner is primary healthcare. We are told is the entry point, and we are happy we have the Edo State Executive Secretary for Primary Healthcare Development Agency, Dr. Mrs. E.O. Obarisiagbo. Can you come to us? Thank you. You know, Madam Chairperson, we've had 3 executive secretaries now, and the 3 of them are women. So I think our government have done well, isn't it? Yes. So we have another woman to talk to us. Thank you.
Thank you very much. Good morning, Chairman, Professor Koje. Prof, thank you for having me. Our keynote speaker, Professor Mwagoja, very well done. It was very detailed. My people, Wadomo Alamogun, I'm very happy to see you here today. There is no primary health care without the community. So I'm happy you are part of this discussion. Thank you for coming. All other protocols permit me to stand on the existing protocol. Today we're talking about WAC, and I understand it's WAC's birthday today. So even though we've not done the happy birthday song, happy birthday to WAC. Congratulations, sir. Thank you for your contribution to health. Worth emulating. So we are grateful for the gift of you. Thank you. today we're talking about the role of primary health care for the equitable delivery of maternal health care. And our chairman has said a lot. So, my role as Executive Secretary, Edo State Primary Health Care Development Agency, is to tell us what we are doing and what we hope to do. What the keynote speaker has presented to us, yes, it's true. But His Excellency, Mr. Godwin Obaseki, has this vision to reinvent primary health care the way we normally know it. So it's a rebranding and a representation of primary health care that we'll be seeing it's happening already. It's scaling up into our various communities. And as we work together, the results will be faster. So the data that we already have is true. Women die from pregnancy, childbirth, and it shouldn't be. And next, what we want to happen is that using our PHCs, our health center, that should drastically reduce and then stop. So then we can conveniently say no woman is left behind. So for people who have looked into primary health care, talk about it's been recognized as the cornerstone for healthcare delivery to our people. And His Excellency, Governor, is very passionate about this because it gives us the opportunity of getting care where we live and work. For us to be able to achieve that, we have to work together. Keynote speaker mentioned vandalism, community engagement. Those are things that we can work together and ensure that does not happen once we are equipping our primary care centers the way we are doing now. So this picture is staff of Redo PHC. You can see how happy they are looking. And that's one of the gains from what the governor is doing. Our people who work in the facilities, they are seeing the changes and they are happy. And then they are very committed and passionate to bring about this change so that our people, our women, our children, even the men, we're changing the narrative. The people's concept of the healthcare center for women and for immunization is no longer true. Because with what the Excellency is doing, infrastructural upgrade, bringing doctors, ensuring 24-hour service is a family affair now. You go in, you get care, and you are happy. Oedo PHC is a good example. You can go in there and see for yourself. It's along Tapley Road. So for that, it now becomes where anything happens to us at home, anywhere, working with His Excellency and making it happen, it means that when we are ill in our communities, you can go to Robioge and see staff there, Robioge PHC. And it's not a situation where you say, nobody did my PHC. Because what we are even doing is to engage like a grassroots, bottom-up approach. Yes, our fathers and mothers in the communities are there, involving our leaders, letting you know the new PHC that's operational in Edo State. Our healthcare workers in the communities, I work very closely with them. We have the head of local government administration, the Hogas. They've been fantastic. Talking about government support, Professor Agoda, talking about government support, the deputy governor is very, very into primary health care, our immunization coverage. What are we doing? How are we doing it? Even before we carry out an activity, we have the task force on immunization. It's us stakeholders, all the organs, they come, the heads of the local government administration, they come, the state immunization officer, myself, the Honorable Commissioner for Health, Professor Obe Akoria, is one woman who is tireless in improving our indices in Edo State. She works very hard, carrying us along, ensuring that we're dotting our I's and crossing our T's. So for such programs, partners are also fantastic. WHO, UNICEF, we sit down, we look at the plan, and then we say, oh, okay, why don't we do it like this, why don't we do it like this? And at the end of the day, when we get in objective assessment from WHO, then we know where we stand, lessons learned, so that it can be better. The dynamics now is to change the narrative so that our indices don't go down, but go up. Less people being sick, less people dying, especially our women, because we're discussing women today. So when we assess care in our PHCs, we can treat common diseases, fever, malaria, we treat. And some of the things that you will see in my presentation is that we are putting laboratories in our PHCs. We are putting doctors. His Excellency's vision is one functional PHC per ward. That functional PHC per ward means we have a new minimum, which is even a bit beyond what we say primary health care should be. And in looking at our infrastructural upgrades, we have a small room that say, oh, this is our mini theater in case we have emergencies, you know. And you know that when these things happen, there's no notice that, oh, somebody wants to faint, or maybe there's an accident and we need to quickly save a life. And then you have the qualified staff in PHC ready and waiting, and the work gets done. Thanks. So using our PHCs and working with our staff, access to care is improved, getting better by the day. Next. So for our community-led interventions, Professor Okonofa, you've done a lot of work. I felt it right to cite one of your work. It has been proven to address specific concerns of women relating to bottlenecks they experience in accessing care in primary care centers. And addressing those bottlenecks will have more women accessing care, and I will share data with us as we go on. So what do we do in Edo State in our primary care centers? We render antenatal care. This is a picture of women who have come for antenatal care in one of our PHCs, take deliveries, and after delivery, mother and baby check in postpartum clinic, and then immunization services as well, family planning, talking specifically to women. But like I've said, it's a bigger affair now. So some of the strategies that we've adopted and working with in reimagining primary health care in Edo State is one that His Excellency had to decentralize healthcare. The emphasis is that you shouldn't, you know, the delay in getting care. By the time you say, oh, okay, there's a problem, you recognize that there's danger, getting to the health facility, you're losing time. But his dream is to have a functional PHC where you can go to and the person be saved. And then we reduce number of persons who die from such conditions. So decentralizing care has brought PHC to the focus. And in doing this, strengthening PHC services is what is currently ongoing. There's a paradigm shift now in PHCs in Edo State, leading to enhanced efficiency, better care, and improved healthcare service delivery in our centers. So I've talked about the new Edo PHC, and then another beautiful thing is that we have PHCs all over the state, like has been mentioned, and they are at various categories. We have health posts, we have health clinics, we have primary care centers, depending on the staffing needs in that PHC. So that also tells us the kind of service we should expect in PHC. So when we talk about infrastructure upgrades, minimum of 2 doctors per PHC, mini theater, the doctors, the nurses, the lab scientists, on-call rooms, they are there, they are comfortable, providing what you need. Then there is care for anybody that goes. So this is a picture of Obioge PHC. To my right is the Oedo PhD, some of the upgrades going on. And then for personnel, His Excellency has approved more doctors to be employed in the system. My people are very passionate to work. I say my people because they are very responsive to the directives as we are getting them, and they are very hardworking. So I must commend them and continue to encourage them for being part of the change and being champions and agents of change to actualize the Excellency's vision of having quality care in our PHC. It takes two, so Bona or one. So we're working together. That's teamwork, one of the core values of the agency, and then making progress. So the gains in the decentralization has brought about the positioning of PHCs in those states, and then we are better able to provide quality care and appropriate referrals, being able to refer as at when due. So our utilization rate has increased. People are now using the PHCs more than before. Because, for example, for Oedo now, there's a doctor there. So when you go, yourself, your family, you see, and not just Oedo, in PHCs in those states, there are doctors. We have PHC coordinators who are doctors in charge of the local governments. So I just thought I should share with us some of our statistics for first quarter, January to March, and then times full of this. And then we'll see that there's progressive increase in records for patients who come to the PHCs. This is for antenatal care, first visit, fourth visit, eighth visit. This is for family planning. More persons are coming to use our PHCs and take the family planning commodities. This picture shows a session where women are being spoken to before the immunization is given to their children. Health education is key. Our keynote speaker mentioned knowledge. It's key, power. So everybody being in sync with what is going on, then we all align and then can work together and actualize our goals. So this is our delivery rate per month. Please follow. We looked at from May last year to March this year. You can see the spike came up when we have doctors in our PHCs. And our people have been doing 24-hour service. Very, very motivated staff. So this our success story is the story of a set of triplets. 1st of April in the 2 PHC, there was to my left, triplets were born at 2 p.m. in the afternoon. And like I said, I'm in WhatsApp group with my people. Somebody just put a picture there. I said, we have triplets in our PHC. So I called. And I spoke to the doctor, Dr. Paul, and what is going on? I have a set of people. I'm like, wow, how are they doing? They're fine? Yes. Okay. Before I knew it, by the next morning, there was another report, another set of triplets. This time, they were preterm. Please, go down, please. They were preterm. The first one was term in Esako West, PHC J2. The second one was preterm in Ikin PHC in Owan East. And the hogger, Mr. Chris Yam, was quite supportive. The PHC coordinator, Dr. Aige, fantastic. We worked together, like, please bring those babies to EBTH because they were preterm. And if the staff in the PHC were not competent staff, we will be celebrating this story. So that's for us to now ensure that, yes, it's not perfect now, I know, but we are making progress. And with the lesson from COVID, with having the lockdown, nobody can go anywhere, even if you have private jets, it's for us to now lift up what we have. And that's exactly what His Excellency is doing for us. So what are we now doing as part of our strategies? We've been doing a lot of training for our staff in the health centers. We've done, now we're talking about key performance indicators. It's activity. And I don't know, what have you done? Balance scorecard. Right, we have our plans. Oh, this month we want to increase the antenatal attendance by 2%. We want to increase the customer satisfaction, talking about our patients that they are happy they came to the PHC. They came, they sent somebody there. Because from that, I, as executive secretary, am able to judge, to say, oh, director, you are doing well. Director, no, we've missed it here. So that we can be better in what we are doing. So, His Excellency has also been gracious enough. We have drug revolving funds coming on board in our facilities. The flagship ones, we have the Dogbo, Oedo, Bekun, Awogba, ensuring that there are genuine drugs in our PH. Because when you talk about pull factors, you talk about the personnel, are they skilled? They sabi work, and then we have that. And then the drugs, we've done the assessment of the patient. We want to now say, oh, there's lab, go do your test. There's genuine medicines for you, and then you take it. And at affordable care, affordable. So it's one way that we can help ensure any difference in socio-economic status. This woman get money, this woman not get money. This woman go school, this one not go school. Go to the PHC. There's something for you. I'll talk more about healthcare financing. I want to mention the basic healthcare provision fund and then the health insurance. So it's for us to work together, and then we'll make more progress. So while in April we had an activity, medical outreach by His Excellency and the First Lady, Mrs. Betsy Obaseki, lovely mommy. She thought it wise to work with, to have Association of Nigerian Physicians in America. Like 65 of them, they are Nigerians. They came and said they want to give back. And then we, as healthcare staff and workers in Edo State, we partnered with them. We all came out too. It wasn't a one-man show. And it was a seamless union. There was no interprofessional, I'll be doctor, I'll be nurse, I'll be lab scientist, not come near me. You not be my, no, everybody was just one. Even the volunteer, clinical, non-clinical staff, and over 10,000 persons were attended to. I'm sure most of us saw it on TV. There was free medical care. There was screening. We had free screening in the 3 senatorial zones in Edo State to ensure that our people who need surgery, we properly select them and prepare them for surgery. And when the doctors came, our doctors, EBTH, and those specialists, everywhere, worked together, had the surgeries, glasses, over 3,000 glasses were given, free. And people were happy. The surgeries, even though when our friends, our brothers and sisters that came from America had gone, we still had patients lined up for surgery. His Excellency was gracious enough to pay and say everybody is free surgery. Let's continue. So the surgeries continue. So I'm very happy when we talk about political will. I like government support. This one we are enjoying now is fantastic government support, because the legacy he wants to leave in health is, especially at the level of primary health care, to say we are able to ensure that there is water in our PHC, there is power, the infrastructure upgrade is what can give us the minimum services, save lives, and then what's our own inside, but to work with His Excellency and protect whatever investments that we are going to now put in our health facilities going forward. So as part of that program, there was a training too for 22 doctors and nurses from the 18 LGAs on Happy Babies Survive. Professor Goda talked about training them Happy Babies Breathe previously. So this one, they brought doctors, pediatricians, who brought mannequins, babies, and demonstrated, doctors from UBTH as well, they were there, neonatologists, Dr. Pompa was there, and then the high-level specialists, when we go abroad, the one that is higher than what normally we get here, people who are practicing in America, guiding us along, teaching our doctors in the PHCs, they're from the LGAs, my staff. See how happy they are in the picture. I told them, you must give me a group photograph. And that was done to the left. And then to the right is the activity. I was there to ensure that this thing is, my people are getting it. Please ask questions. you are going to step down this training. You are going to do exam, you know. So they really paid attention, and it's one initiative to help our baby survive after delivery in case there's any issue. And when we say skilled staff, we're doing our best to ensure that, yes, we can really answer to it, that our staff, they are skilled with the training. I talked about the drug development fund training. We have seasoned pharmacists, you know, facilitators, Dr. Sanedege, pharmacist Olumese, and Dr. Ekpefan, who start ensuring that our people, pharmacists, pharmacy technicians in those states, they're trained. And talking about the drugs, we are using, we have computers in our PHCs. I'll talk more about it later, where we see our patients, we enter the data, and we're able to look at it from the back end. I can be in my office in Ring Road, and I'll just log on and say, oh, in Ukpenu PHC, yes, they are working. Because if you are not working, then your system is down. Now we're looking at it from the back end. And then if there's anything that happened overnight, a mortality, we can also see. And then we'll just call. Another beautiful thing with the computer is that with the Honorable Commissioner for Health, working with doctors in HMA, you know, Hospital Management Agency, to work with our CHOS staff in PHC. If there's a patient that they are not able to handle, so we don't have unnecessary referral, just log on, put a phone call, we're able to do video conferencing, telemedicine, and then resolve the issues. When it's not resolvable, then you refer appropriately. So that's going on. For the laboratory services, we're a functional lab, and we're upscaling. What we're doing now, we're scaling it up, getting proof of concept that yes, this works, learning from it, and then stepping up to higher levels. And then for our lab, we talked about mothers dying from malaria, from anemia. We're able to do the test, detect, and then treat and prevent that from happening. For the direct community engagement and ownership, you know, I was very happy. I celebrated my daddies and mommies here, for being here. It cannot happen without your participation, getting our people to use the things properly and go to the health facility. And as we are coming with the messages, say, hey, immunization, no carry our children come out, maybe give them the vaccine, make polio not come, make hepatitis not come. Then our people are sure that we are not trying to do them wrong, but we want to improve our health status. Saying no, COVID-19 vaccination, maybe we vaccinate ourselves, maybe protect ourselves, so that God forbid it come again, we don't stand gidigba. Because the virus, it mutates, and it's what virus do. But if we take the vaccines, we take our shots, our system is protected, we are stronger than if we just leave ourselves like that. God forbid, then we're talking about more deaths. So working with our leaders in our community, our John Way, our Inogie, you know, our women leader, the youth leader, our women, our children, they are better protected. We are safeguarding our tomorrow, and then we'll all be better for it. So for the use of technology for patient care, it's happening in our PHCs. I can just call and put my phone on video, WhatsApp, Akoko Edo, say, okay, what's going on right now? Turn on your video. Are you where I said you should be? You know, and then they show me, and everybody knows. With technology, nobody is far away anymore. And then the information flows both ways. As they having their challenges, I'm also very accessible with our own levels of cascading the care. My team of directors is tireless in the work to ensure that this one now is mosquito contact. PHC should really be. I'm marking each other to help ensure that tomorrow, what we get tomorrow is better than what we get today. Using the lessons we are learning and moving forward. So for we have a strong infrastructure for immunization activity across the LGA. I talked about the task force on immunization. When we're doing our supplemental activities, we did the outbreak response to polio because of the circulating variants of the virus to protect our children with the novel polio vaccine. That's not readily available in the normal day-to-day immunization. So Doing that, we have evening review meetings, like in the evening, I've gone to the field. Okay, what happened today? What are the issues? We need more people, we need more team, we need more this, and then we arrange it and sort out the challenges so that the next day is better. And that's working together like that, we're recording steady increase and progress. But there's more we can do. So talking about more to do, there's the State Emergency Maternal and Child Health Intervention Center, the STEMCHIC program. It's one way that we can implement the BACPF and have better reproductive, maternal, child, and adolescent health services, even with nutrition services. And that's really we strengthen our response using our PHCs. And mothers, women of reproductive age will benefit from it. They will be more responsive. Next. Same with the community health influencers, promoters program, which that's still in the formative stage. We're rolling it out. And for this one now, it's more of the community engagement, having members of the community, at least 10 in each community, to be part of what happens in the health system. We're also working with our ward development committees, and then they've been helpful on the health part of it to ensure that the quality of care we are giving our PHCs, we are getting better by the day. So for more on the healthcare financing, we should know about the Basic Healthcare Provision Fund. It's a fund from the federal government, 1% of the consolidated revenue that comes. And so the primary healthcare part of it is 45%, the insurance part of it 50%. And for the insurance part of it, you have provision for the vulnerable, those who don't have money, to be able to get care when you register them under the scheme. So it's not only for Lare Duasa, it's also Lare Gagbaogewe. Come, let us take care of you. If you are in that category, you are able to pay for care, fine. But you also know that the care in PHC, taking cards, average of like 200 naira for a card, you can't compare it to when you go to private health center facility. So if we build on this progress, able way little drops of water makes a mighty ocean. Wow, progressing by the day. I can assure you in the next 6 months, it will be made clearer, and we'll be feeling it in our various communities, especially as we also come on board to say, okay, we are here, what's next for us? And then we're working together. The agency has a vision to be the most responsive of the state primary care development agencies in the whole of Nigeria. And this we hope to achieve using direct community engagement and a high-performing workforce. So those two things have been key for me, so that we can deliver our package of preventive, promotive, curative, even rehabilitative care in our primary health care centers. So there's a lot for us, just for us to be patient and work with us. So for BACPF, currently we have like 142 facilities who get this allocation, and then we're able to provide for what the facility needs. In the target is to get one BACPF facility in the 192 wards, and that's also in line with the Excellency's vision of having one functional PHC per ward. So, of course, with the BACPF, we have services, antenatal care, we have drugs, we have postnatal services, delivery services, and then maintenance of the facilities so that it's not dilapidated, and then room for having midwives, recruitment of midwives in the facilities, and making it functional. For the insurance I've spoken about this, so far they've enrolled over 25,000 persons. The DG is Dr. Rock Amego for insurance, and then they're still actively working as well to get more people into the program, and the enrollees include pregnant women and vulnerable people. So for this, it's the e-class, the computers in our centers. It's what we use to see patients. It's not in all PHCs, like I've said. The PHCs are of different categories, but where they are, we used to see patients, and we also use it for our drug revolving fund. Drug revolving fund, where we ensure that essential drugs are available in our PHCs. A center, so it's cashless, it's POS to ensure transparency and accountability. because when we're able to grow that, we can scale up to the 18 LGAs and have, if we start 222 now, as we're making progress, before you know it, we've made considerable progress across board. So these are still more of the advantages of ICLAT, and that's I walk back. I know they sit down for office. I will go and see for myself. So I went, this is I walk back PhD. Successfully used the computer to actually see patients, enter the data, looked at the back end, reviewed, saw what they've been doing. But clocking in, clocking out, you can't work today, you will log on. You don't log on, that means you no can't work. That's part of what the computer is doing for us. So our people are getting used to it, especially for that you can't work. So telemedicine clinic is operational in Oedo since April that the AMPA program was done very successful, thanks to Her Excellency, Betty Obaseki, and our governor, Bell, and our commissioner, who is very passionate about it. So even today, doctor in America, you see patients for PhD, for Oedo. So every Saturday, Dr. Philip Oselbo, he runs that clinic. So for me now, is to upscale it, to get our doctors in UBCH, those specialists, to also say, okay, we'll be seeing patients, whatever clinic that will have a computer, 1 hour a day, or 1 hour Saturday, after they don't play ball, finish, if it's a man, or if it's a woman, after I don't cook for us, finish. Say, okay, let me consult and see patients. So what happens is that you are sitting down here, the computer is on, doctor in another place is talking to you, seeing you, and making a diagnosis from what you have said, asking for tests. And we on ground here, we're also working to ensure that all goes well. You finish drugs are recommended, and then you go home, you're happy. So these are some of the things that we've been doing, and some of the ways that we can ensure that our women get equitable access to maternal healthcare services in our PHC, so that no woman will die. So from what we discussed now, I hope I've been able to show you that primary healthcare plays a major role in equitable delivery of maternal healthcare services, but building on current gains from the decentralization of healthcare in Edo State, we're empowering our women, giving her this information. We'll have state health educator, Irene Owabo, with her team of health educators all over the synergies. Once we just send the message here, it carries round with the town announcers, involving everybody, letting women know, and then facilitating the participation of our community leaders, our fathers, our mothers in the community. We hope that we will continue to improve utilization of our PHCs and improve the kind of care our mothers get when they come to PHCs, so that no woman is left behind. Thank you very much. Next slide. So I'm saying thank you, but this slide now you can see His Excellency, we are still working. We never rest, because we know we are not there yet. Thank you very much.
Thank you very much, Dr. Baisiagbo. You are still working, and we want you to continue to work. Isn't it so? You know, community, don't worry. Community physicians are like that. They want to be inside the community all the time. I'm sure Igwe Heya will ask you to come and cite one PhD here. Abi? Abi? After all those beautiful talks, so that our own women here too, we have our women and children here will be included. Madam Chairperson, we've had the beautiful talks. I want to ask if we take questions first before you summarize, or you summarize before questions. Okay. Okay, she will give us some pep talk, then we will engage the two lecturers. I assure you 1 o'clock we'll be out of here. But don't go without your lunch.
Thank you very much. So I want to congratulate our two speakers for enlightening us on the challenges of maternal and child care in Nigeria. So the things I want to highlight from what he said are the following. Firstly, about it is not that the problems have not been identified. They have been identified. And there have been a lot of global concerns, the MDGs, SDGs, all of them. And so many policies we have heard about, safe motherhood, global this, global that. But then he mentioned that implementation was the key challenge. I have had the opportunity to evaluate 2 programs, the policy project and then the enhanced project. Those 2 projects dealt mainly with health issues. There was an interval of about 2 or 3 years between the times I looked at those 2 projects. And I found that things I saw with the policy project, documents and things I looked at, this policy, health policy, whatever it is, by the time I came to evaluate the enhanced project, this set of ones I saw in the policy project had not even been implemented. And one of the problems is because they have not been domesticated. Governments will not take up something if it has not passed through the legislation and so on, and it becomes a government policy. That is why you find that they are abandoned. And that was part of my suggestions then, with all these people who invited me to come and evaluate this project. ILO will, a health project to come and say, okay, we have money for 2 years. We want to support this program. They set up an implementing agency, give them money. We are looking at malaria. At the end of the 2 years, the money is finished. Nobody takes it over. So that is what has happened to many of these programs that we have been, and that some of those that he mentioned. The funding agency only says we have money for 2 years. Because I raised that point, that what of sustainability? What happens after you say you are going away? Because some of these projects, these people are evaluated. By the time I got to their agencies, most of them, the project had ended. They just told the people, wait for the consultant who is coming to ask you questions. All the tables, everything, they had disposed of them and so on. So I asked, okay, what happens? You are going away now. What happens? Who is taking over this project? So that is what is happening. Because I have quarreled with some of the international agencies that you come, you say you have money for this project for 2 years. Who takes over after you are gone? How do you ensure that the project does not die? So that is what is happening. There is a need for either for the international agencies to change their approach and see that these projects are integrated into the government policy. You have heard what she is saying now, from what she presented. Your projects are working now because the present governor is interested, and he has taken it as his project. What happens when somebody takes over in 2024? Somebody who is not interested in all your what do you call it now? The primary health care programs. The primary health care has been there for years. As part of my jumping about, I went to the national office to go and ask them, what are you doing as part of the work I was told to do and investigate all these things. If the person in charge, because what I have observed is that if the person in power is not interested in that project, it will not see the light of day. That is just the truth. These agencies and these programs have been there for years. During election campaigns, they show us pictures of these buildings, rickety, some with no roof, no this, no that. At least the ones you have shown us now, they were looking fine. So I don't know whether that covers all of them in Edo State or just a few of them. Because if we are to reach all women, then everywhere, the primary health care buildings should be there, they should be functional, doctors should be there, nurses should be there, drugs should be there, not only in Edo State, all over the country. That is where you can reach all women. If all these buildings, primary health care buildings, are everywhere, then some of these discussions may not even be necessary because every woman will already have access to it. So that is one thing there. That is where the political will comes in. It depends on who is in power. Then funding is also very important. If the government is not interested, it will not fund it. will not provide funds. And then the way they do the budgets in Nigeria, I had to evaluate for my society, Nigeria Economic Society, to look at budgets, evaluate budgets for our annual talk. You find that they will say, okay, a project is going to cost 10 billion naira. Then this year you will allocate 500 million naira. What did that do? What did that do? Because the government is spread thinly over so many things that they only allocate small bits of money. If you give 500, you want to tie a road. Look at the road from Abuja to Benin. That road project has been on since Obasanjo's time. Since Obasanjo's time. Every year money is voted for it. But how much? You know that the project is going to cost 20 billion. Then in 1 year you give 1 billion. But that will not do anything. By the time they scrape the sand from 1 kilometer, 2 kilometers, that money is finished. And then you wait for the next year. That has been the problem, one of the major problems why things don't get done in this country. When Buhari was going to come to government, he was making fun of the Jonathan government that all they do on Wednesdays is to be approving projects. What are they doing now? It's not the same thing. After every meeting, one minister will come or two ministers and say, this amount has been allocated for road, this amount has been allocated to this road. How much have you released? But that is the important thing. It is not just telling us that you have done, you have awarded a project for 20 billion, and then that year you only give RCC 2 billion. When the 2 billion finishes, RCC will pack their load and go somewhere else, which is what is happening on our Benin, Abuja road project. So proper budgeting has been very, very effective. So I was happy to know that we are dealing with communities. But now in the state we are at least we have the community representatives here, all elderly people. We are the young men. We are the young men who are marrying the wives now, who need the access to the primary, to the health care, reproductive health care. I hope we are not marrying new wives and all the rest. And having babies, because those are part of factors causing overpopulation in Nigeria. Men, when they are already 80 something, they go and marry another young wife and start having children, leaving a burden for their children to look after. Because the first one is now loaded with babies and children to care for. So where are the young people? Because that was where my concern came about. I will still leave my reservations until after the questions. So please, those who have my conclusion, those will be in my conclusion. If you have questions to be, now that they are still here, I will take questions. Make your questions to the point and brief. We have already had lectures. Now we want questions.
Thank you very much, Ma. If we have concerns, interventions, so indicate. So we take, and the lecturers are here. The community lady is here, smiling away. Is it that they didn't talk to us? Yes. Okay. You have. So number one. Any other? So when are you going to cite a PhD in our community? That's my whole question. I know you have a PhD at Oluku Junction, and then you have one at Oyoge. So are we expecting one here? Or what do you want us to do? I'm a member of this community now.
A question that I've always had in mind. So it's okay. We were teachers, so I used to stand in. So when Governor Shomole was going to second term, they invited me to be the chair of a program they had for him, to sell him. And one of the issues I raised then was that, why can't we have mobile health services? In some of the advanced countries, they have flying doctors and all kinds of things. You have a PhD, a center now in Oluku. But not everybody can go from where they are. So local and access it. When my late brother-in-law was a doctor, then they used to go to communities. They would say, okay, we are going to this community on Monday. We are going to this one on Tuesday. So those who have health challenges will be waiting. So since why can't some of the, well, if you now have doctors there, why can't some of the doctors have, provide them with an ambulance? And then some days of the week, they visit some of these communities. And then only those who now have challenges will now come to the primary health care center for treatment, if necessary. We already have politicians and some others doing those kinds of outreach programs. Even the one you did with the Americans, something like that, they came. So let the doctor go to the community and meet the people instead of waiting for the patient to come to the hospital. Because some of the distances are not possible. Some of the places I have passed through in the process of doing over-study work. Some of the villages I have been to, especially in the north, it is only on market days that vehicles can go there. You can't pass. In fact, when I went to one of the communities, when I got there, I was treated like a governor's wife, VIP, because for many weeks they had not seen anybody coming to that village. So they had told them that UNICEF was part of the girls' education program. We were evaluating that we were coming. They are good for us, prepare for us, because they don't see people. Some of them, and there was another place I had to pass through, river with no bridge. We had to drive through the water. I was telling the place that anywhere you know your UNICEF jeep cannot reach, don't put me there. I will not follow you to the place. I'm not going to go and die in that community. How do you reach all those places? It is maybe the doctors can visit instead of you expecting all these people to be coming to you. It's something that can be integrated into this when you are doing at those states now. Let the doctors, maybe once or twice a week, visit some communities, identify those who need further treatment, who can now come to the center if necessary. Not everybody wants to be coming because they have headache, they have malaria, they have. That's my question.
Good afternoon, everyone. Please permit my voice. This is not my real voice. I humbly wish to stand on existing protocol. My name is Bridget Imwetiyansai Godala. By the grace of God, I am a lawyer and I'm a friend of work. Anytime I'm invited, I love to come because I know that whatever they are doing is up to standard. And that is what we have seen here today. I'm not bothered about the hall not being filled. I've learned a lot today. I want to thank our keynote speaker. I want to thank Madam from who spoke on the primary health centers and programs. I want to thank you for taking time out to be here. Indeed, you are a friend of work too. I believe that you are a friend of work. All throughout the guest speaker's presentation, I was really, really interested. And I had to leave when I got a call, one, two things, and I came back. Sorry about that, madam. I actually wanted to sit okay from the beginning. I would like to start from my personal experience before I go to my questions. And maybe if I'm allowed later, I'll talk on this particular discussion we're having. Personally, I've had 4 children. I've been to the world 4 times. 3 are alive. I've lost a child, so I know what it means to lose a baby at birth. And I've also had personal experience from people. Some years back, I was in Bible school, and one of my classmates, a pastor now, told of how his mother gave birth to 9 children. He was the only one. He's the only one alive. 9, the 8, they died at birth. That is where we come to the area of stigmatization. I'm very happy that our elders, he told us something then, that the mother was stigmatized, in quotes, for losing children at birth. And it could have been by complications whatsoever that could have been handled. but by the grace of God, he survived. And I'm standing here today to say, when Professor Lawrence spoke about monitoring maternity mortality rate being monitored in a particular year, when Professor Beko was in charge as Minister of Health, that was very striking to me. If we can do that, I don't know whether it still exists, madam. If there's a way it can be monitored, these committees, if it's existing, if it's not existing, if there's a way we can work on it, so that this maternal mortality rate monitoring committee can be revived. We go around, not just for government hospitals, even these your PHC centers. Let's enlighten them. Let's talk to the community people. They are here now, so that we know that when these things happen, you don't need to say, oh, in quotes, put it over, spiritualize it, or name the woman, give the woman names. Maybe it's her sins, what she has done. So my question is, do we still have this maternal mortality monitoring committee in existence, or do we have something like it that we can use to check on this, so that doctors too will be on their feet if it's any fault coming from them? I would like to quickly say something, that when I lost my child in 2011 due to complications, few months later, my in-law had a baby abroad, just like you said, sir, that the rate of survival over there is very high. The same issue we had with our baby was what happened over there. But it was just a simple surgery they did before that child was delivered. With just hospital equipment, they used it, and the baby is alive today. So I also want us to draw attention to what do we have in these centers, in our hospitals. You could have complications that maybe a particular equipment you have at hand at that time could help. Do we have them? Do we have them? Where I gave birth, it was not there. So the baby did not survive. We could have been a case of one baby rescued from such complications, but it did not happen because the equipment was not there. Then another one I noted is, sorry, let me just quickly go down. You said something, Professor Lawrence, sorry sir, I know we are trying to keep to time. Let me just round up with this, yes, a minute please.
While you are looking for your question, okay.
You said something, sir, Professor Lawrence, sir. How do we get, you said that, I like your illustration with the jet or the plane crash with people inside. The government, they don't bother when it's just 3 or 4 persons, it's news, military people. I have here, how do we get the government, stakeholders, community members, how do we get them, how do we make them become bothered about the high rate of maternity mortality in Nigeria and Edo State in particular? The government, it's not just for us to say it. How do we really get to them and make them, in quotes, shake them? We may not have to protest. How do we draw their attention so that they become bothered, if it is true that they are not bothered? Thank you.
Prof, I hope you took note of the question. She spoke like a lawyer, plenty words. I heard they used to pay lawyer per words in those days. The journalist has a question, so you tell who you want to ask. I think that is the last one, so that we can go for lunch.
My name is Gabriel Enogolase of the Vanguard newspaper. My question goes to the representative of the government here. I'm talking of Dr. Baishagun. In those days, we used to have what we call traditional birth attendants. In fact, they were the first port of call for women at the point of delivery. Do we still have them today? And if we do, what is the government doing to ensure that they are properly trained? Thank you.
Okay, now that is for who? Dr. Baishagun. So, but you will start first, please, because you have to build a PhD for B.
Okay, thank you very much, everyone. Let me start with my chairman's question. or suggestion that the doctors should go into the community and do home visits. Okay, that can be done, ma. But what we are currently doing, we have the community health extension workers, you know, whose job actually is to go and check on the people and follow up. Me, I'm a very practical person. When I come here and say my doctors will now be doing home visits and they don't do it, we will see in another forum tomorrow, and then you will ask me. We talk about staff for PHC, which His Excellency is building on by giving permission and approval for employment of more doctors. The PHC idea is for care at the health facility. If you need follow-up at home, you have home-based care to follow up. If you need referral to the next level, like Madam's question, where maybe the woman is pregnant, that situation of the baby was seen on ultrasound, that's not the level of care we expect to give at our level. So we send to the next level, secondary care or tertiary care. So that's how that operates, ma. For the other question regarding the traditional birth attendants, yes, we have traditional birth attendants, but what we noticed as part of what Professor Amagoja also presented was some contribution to maternal mortality, in which some of the programs which he also told us about train them to recognize danger signs in women. So the level of participation there is that if you know that the blood pressure of the woman is very high, it's not the one to give birth at home. If the woman has been in labor for a while, you know the labor is obstructed. If you insist that the woman should give birth at home, the woman dies, and you may even lose the baby. So training has been ongoing for such, and the WHO recommendation is actually that they should be part of us to say, Madam, as you just did so, you don't born 5 children, for example. It's not for delivery at home. Go to the health facility. So we're like improving on the responsiveness of the community to ensure that all goes well. Because for once you get care, we talk about delays in healthcare. The delay in even me, myself, identifying that there's a problem is one problem. Delay in recognizing danger signs. The woman is pregnant. You don't see water since morning. Maybe the pain never starts. It's that for us. Or you don't see blood. Or you don't see, you know, they feel anything again. See there. Delay in recognizing that there's a problem is very big. And so apart from looking at that and getting to the health facility as soon as possible, we also want to ensure the sustainability issue. I think from the experience we've learned with COVID, or us as humans or as stakeholders, one doesn't change a winning formula. If they do something, if they work, you can't change them. So waiting now. What we have done that we succeed in, I want to believe that the next government will want to also piggyback or even improve upon it, because the biggest room in this whole wide world is the room for improvement, so that everything can be better. Thank you very much.
A few questions for Professor Amagoja. Okay.
Thank you very much. You asked whether the committees for monitoring are still there. I believe they are still there, but how effective they are. But more importantly, we have what we call the maternal and perinatal death surveillance response, okay, or reviews. It's a big committee set up by the federal government. It's a committee that came up from the level of the Council of Health, Council of State on Health. So they track problems, death and or near death for women and children. Then, of course, periodically they review them, look at what had gone wrong. It's not judgmental. It's not meant to punish anybody. It's just meant to improve services and facilities where they come in. Like you said, if we had one equipment or the other, probably the baby would have been salvaged. So they try to draw out and bring out all those connections. What would have gone wrong for us to have this situation, a near miss or death? Then they now ask what can be done such report is always presented to government through the Ministry of Health from time to time, and that one is ongoing. And of course, there are other interventions. Like I told you, we just wrapped up another one that looked at maternal prenatal death surveillance for intention to improve on the quality, equity, and dignity of care. And that one too, periodically too, we present reports to relevant agencies and hope that it will be put to use. But the problem is not getting government attention. Government attention is always gotten from time to time. But the political will to do something, that one is beyond what I and you can do. We continue to draw attention to that, but to what extent they show commitment is not within what anybody can force them to do, even in a state where the governors are doctors. So that's an issue. Then ask of equipment. Interestingly, some of our hospitals have good equipment, particularly at the tertiary level. At secondary level, the equipment will not be as much as you have in tertiary level. Then, of course, the primary level may not have all sophisticated equipment. So they render basic care. And for instance, let's take a baby that is delivered in a primary healthcare center. What we try to do is to get skilled birth attendants who can recognize problem and do some basic interventions that will make the baby stay alive as much as possible, or the woman, before she's transferred, and then she's transferred to where she can get those equipment. That's the way it's done. For instance, like I told you, we some years ago when we send nurses to the rural areas, we found out that they had challenge with managing babies or resuscitating when they had problems. So we had to set up this Helping Baby Bridge initiative, train them, which is like Helping Baby Survive that she showed you. So we teach them on how to resuscitate, how to intubate the babies, and do quite basic things that can rescue the baby before they transfer them. So that's the kind of situation we find. Unfortunately, we can't have all equipment in all levels of our healthcare the way we have in developed countries. Thank you.
Well, discussions will always be ongoing, can never end. And this seminar today is being streamed live in Facebook, and it will be on YouTube. As friend of work, you can reflect and get back on it. Madam Chair, any concluding remarks?
Conclusion, I hope that we have all listened, we have learned from it. From what I can see, the program is really targeted at reaching the poor women mainly. My own concern is with those women who have been reached already, the more educated, the younger generation. That is where I have some problems. When we started advocating, because as I said before, I was one of the earliest people to start talking about gender with my PhD thesis as far back as 40 years ago. Since then, I've facilitated many workshops, meetings, helped some agencies to write position papers on empowerment of women, evaluate girls' education in the northern states, and so on. I'm not happy with the younger generation, what they're doing. We were graduate wives. We were the first set of graduates. They used to call us Akada women then. We were very few women graduates then. And many men didn't want to marry graduate men because they said that they will not be submissive. Then, but now graduate women are to a penny. Plenty. But many of them are misbehaving and giving a wrong signal to community members, to men and women. And that is why some of the policymakers are reluctant to support policies that empower women. Let us be frank. When you read the social media and things now, what are you seeing there? Domestic violence. It's what all we are seeing now, hearing now. A husband beating wife, wife beating husband, stabbing themselves to death because of empowerment. That was not our agenda. Then when we started, I have been married for 53 years now. 53 years. Our own program was then that empowering women will help them to be better wives. That was the argument that education makes a woman a better mother, your children will live longer and all the rest, you can look after children. But what are we seeing now? Something different. So that is what an area I would like work. Instead of looking at the regular types of studies, start looking at those ones. What is happening in families? We don't want to get to the situation that they have in advanced countries where over 50% of marriages end in divorce. We want to be empowered as well as to have stable marriages and homes. We have all seen the challenges of broken homes and in Nigeria now. Violence everywhere. Yahoo boys, Boko Haram, all kinds of things. So those are the areas I want us to now start looking at the non-conventional areas. Start examining the why is this happening. Then following from that one is that marital infidelity has now become widespread because of free access to contraception, to different things. That may be a reason. I want you to look at it. Because now we hear of baby mamas and all the rest of it. The first time I saw baby, I was asking my daughter, what is the meaning of baby mama? That is not why we want access to reproductive health services. So those are areas that need attention now from researchers. We should start looking at things that are trending. Things that are trending now. What is the reason? What are the reasons why such things are happening? Because we want to continue to empower women. We want to continue to educate them. Then finally, I also said that when we started selling gender, because I was an advocate for UNIFEM then, going to talk to people, say gender this, gender that, we said gender is male and female. But nowadays, we're only talking about women and the girl child. What of the boy child? Who is talking about the boy child? Because these boy children are the ones who become the husbands. Who will prevent the woman from going to the hospital if it's not enlightened? So we need to start balancing all the activities. I know your center is women's health. Or maybe you can put like 30% of your activities to start looking at the boy child because he's going to become a husband. We cannot succeed in leaving any woman behind if we don't also carry all the men along. So that's why I'm happy that many of the male community leaders are here. But the young ones who are reading social media and all that, they're not here. Because they're the ones we are really talking about now. The older ones have done their own bit. And I said, please don't marry any more new wife. Don't marry any more new wife. Look after your grandchildren now. Not your children. So the younger generation are really the ones who we need to talk to. Because most of the problems are among the younger married people. They are the ones who are fighting themselves and killing themselves and so on. Because of female empowerment, because some of them have misinterpreted what submissiveness means. They think that submission means that your wife should become your slave. You cannot say A again before she says A. Yes, I'm sorry, I've done this, I've done that. So let us target the younger generation of families, because they are the ones who need all these kinds of information, how to live. We want to have at least 90-something% of married, stable marriages. Because I will not feel happy that I was part of those who started saying empower women, and then we end up with everybody, all the marriages breaking down. But I'm not happy with the statistics from abroad. When you read it, all you see now is single mothers, single this. All the rest of it. We don't want that. So those are issues that we need to start looking at now. How do we ensure that we have stable names in the midst of female empowerment at all levels. I'm sure those are some of the things that made those in the House of Assembly refuse to support some of those. So they will say, these women, once you give them this liberty now, they will start doing this. But that is not what we had in mind. We early generation of educated women, that is not what we had in mind. That marriage should not be broken, to stay in the one house. Some people before 1 year, the marriage has even, they've separated. Some people are even saying that they will start asking for the money they used to buy actually from the people who got married. It's something for both women and men to be concerned about. I'm concerned about that as an early Akada woman. That's what they call us. So you young Akada women, stay in your homes. You researchers, find out why are all these negative trends now happening. Because if these things are happening, some of the less educated men will not want to allow their wives to have access to all these services. They will not want to allow them to have access to education and so on. So those are the things I say. I know that they are controversial. But then research should be about what is happening in your society. Some of the things we have done before, we have done them over and over and over again. Let us start looking at what is now happening in the society. How can we address the challenges? How can we prevent things from getting worse? We don't want children growing up in single homes. We don't want those who are kidnapping people and all that. It's all part of instability in marriages. So I thank all of you for coming. So please, community leaders, next time, bring some of the younger men around. They are the ones who need the information. Yes, you have to be talking with young children now. They are still talking with young children. I tell you, don't go and marry. I will come and take statistics. I have all your names. I come and find out all those of you who are still marrying young. Thank you very much.
Thank you very much, ma. Thank you. We are indeed working now on gender, and we are having some community engagement. And we have an outstanding advocacy visit to Primary Healthcare Development Agency based on this issue that Madam Chairperson has raised. I want to thank you most sincerely for coming, and we believe you will be here again when we invite you. And like she has advised the younger generation, so that they will know that they are truly the leaders of tomorrow. Lunch is ready, and we'll just file through here. Okay. Okay. So they are ready for lunch, and our program advisor will give vote of thanks.
Well, Chairman, distinguished guests, ladies and gentlemen, is very excited, and I listened carefully and learned a lot. And I do hope all of you learned a lot. And I want to thank you all for coming, despite the fact that this is Saturday normally meant for festivities. So first of all, let me thank the chair lady, or chairman, or chairperson of this occasion. I am very dearly beloved Professor Okoje. Thank you so much for dragging you out of your rest. And I know that you've always been an academic. I knew you from the very beginning as a frontline advocate for women, researcher for women, one of the most preeminent in this country. So I know that in my mind when I was thinking we would chair this meeting in order to advise our men and women. I had no mind. I was saying, the only thing I was afraid of was that you may not have the chance. So when I came to your house to drop the card, I told them not to let you know I'm around, because you might just tell me there and then that you will not be available. But I ran away, and then later on you said you told me to say you come. So thank you very much, madam. And I think she has advised you from her knowledge. When she started, initially I would say, but I think she's correct. That this was not what is happening now. And you know, the whole generation has changed. The Nigeria we now know, it's not the Nigeria we knew several years ago. I'm so afraid of this country. Both in politics, anything in Nigeria has changed. I couldn't even imagine since 2020 till now, I've not left Benin City. I've not even gone to the village because of insecurity and all that. People are being kidnapped. Anytime I hear of a single case of kidnapping, I get worried. I say, but how are people able to survive this kidnapping? And if even somebody close to you kidnapped and he goes through those horrible, terrible stories, how are you going to kidnap? So, I think the major problem is that the whole country has changed. And so our young people are changing along with them. But so what you have just said, I think that maybe if I'll talk to you later on, I think you need to come and deliver something like women's health and empowerment, looking back and looking forward. So that I can tell this story you just said. We can give you an audience to do it. Not only anywhere you want, even if it is anywhere you want to do it, we'll kindly invite you, man. When you are available, when you are free, to come and deliver it. Because very, very important. The advice is given. I want to also thank our Executive Secretary for coming. Again, this is the first time we're having a government official sit with us from the beginning to the very end. And talk openly and frankly, because in the past, people used to be afraid. I always tell them that, I don't think governments are human beings like us. So even when we say something that they may not like, at the end of the day, it will help them to serve us better, so that we will love them forever. So I'm very happy that you came today and explained the perspectives of government. Some of the things I didn't know, and I know. And I hope that they'll go away better informed about the role that this government is playing in promoting health and social development, not only for women, for all of us. So thank you very much, Madam, for coming. And the guest speaker, the one only Professor Lawrence Omoagboja. You are as frank as usual. You are as brutally frank as usual. So, and he has the same characteristic as myself. So when he speaks and I speak, you would think he's my junior brother, even though he's from Delta State and from Edo State. And I think it's because he was my student. So since I was still, I think they know how I used to talk those days. I think I'm less fearsome now than I was when I was younger. So he said it all. We need political will. And political will. We need government to say they will do this and they will actually do it. The truth is that without political will, without government leading and doing things, and all of us following. So thank you for very wide-ranging recommendations. We'll put the presentation, the two presentations on our website. We are developing a very beautiful website, including this particular workshop. It's being streamed live on Facebook. If I was watching it on Facebook. So when I went out there, I saw it, everything was being watched. And it's going to be on our website permanently. So if you go back, and all our friends of Unimen, we have a WhatsApp, friends of WAC, we have a WhatsApp for them. We'll share all the video with them. And if you have questions, continue to ask us. And the Executive Secretary has promised that he will do a lot of things for you. So, community members, one of these I wanted to remind you, Executive Secretary, is that in the good old days, they used to have what they call World Development Committees that work to ensure that when you provide PACA services, that people in the community actually use them. So, and I believe that we have done studies here in WAC to show that the World Development Committee is very useful. For example, Igwe here must have a health center. So if they have a health center, yes. Are you talking before? Yes. Okay. They should work together, and we will be very willing to give you the names. And anytime, I've also told them that if they have any problem when it comes to RET and primary care, we'll be your liaison. So if anything we cannot do, we'll forward it to the Executive Secretary. So, and I want to thank the Igwe community. You came at 8 o'clock. We started free medical services, screening this morning. And I told them that we're going to come at 8. And I actually came at 8. But some of our staff who were supposed to come at 8 did not come. They did come, but they came. And I sat down, I was the one screening them. So, sirs, Mans, we thank you very much. May God continue to bless you, may to promote you, and lift Igwe higher to higher levels. Our collaboration, our friendship will remain for all of us to see. And for all other participants, and Madam, from the Ministry of Justice, may God continue to provide justice in your life, and justice for women, and justice for Edo State. In Jesus' name we pray. And thank you all for coming. May God could take you back safely to our various destinations. Please stay with us. anything you want to, we prepared food for 120 people. So only about 30. So take double if you like, take double and take home with. Double ration for all of you. So you go ahead with it.
Okay. Thank you very much. Thank you. Lunch is served. And this is the dal. No, don't run away. No, high table. Come on now. Somebody, a young man said, why did we pass the law on VAP? Huh? Prof, there is a law on violence against persons. And in Ekboma, we're discussing, and we told them. They said, why did they pass the law without... So, yes, so please, we'll follow you. Thank you, man. So please, can we just go on? Me, I'm hungry.